Hello, myself Dr. Akhilesh. In this video, I will explain about the Wilson disease. Wilson disease, it is a rare autosomal recessive disorder in which the copper accumulates in the liver and various organs and leads to their damage. The Wilson disease is named after the British neurologist Samuel Wilson. This Wilson disease is also called as hepatolenticular degeneration. It is also called as inherited copper toxicity. The genetic defect in the Wilson disease impairs the copper transport. And what is the genetic defect here? In the Wilson disease, there is mutation in the Wilson disease protein, which is also called as ATP7B gene. So the defect in the ATP7B gene, this leads to the decreased production of the ATP7B protein. The ATP7B protein, it helps in the transport, it helps in the binding of copper with the ceruloplasmin, and the ceruloplasmin helps in transport of copper in the blood. The Wilson disease manifests during childhood or the adulthood, but usually between the age of 5 and 35. It affects both men and women. It affects approximately 1% in 30,000 people. The pathophysiology of the Wilson disease. So, from the food, the copper is absorbed, and this copper absorption per day is approximately 1 to 2 milligram per day. But in the body, the copper requirement is only 0.75 milligram. So this excess of this copper is excreted mainly in the bile and some in the urine also. The bile copper, it is excreted in the stool, which is also called as the fecal copper. But in the Wilson disease, what happens is, because of the genetic defect in this ATP7B gene, there is no excretion of the excessive copper. So what happens is, this excessive copper, it will accumulate in the cells, and this will lead to generation of the free radicals, and these free radicals, it will lead to the tissue damage. So look at this slide here. So in this slide, we can see here that the copper, so these dot structures, they are the coppers. So this copper is absorbed from the GIT, and it will enter into the enterocyte. From the enterocyte, it will go into the portal veins, and from the portal veins, it will go into the liver. So in the liver, this copper, it is transported inside the liver, and in the liver, the ATP7B protein is produced, and this ATP7B, what it will lead to, it will bind the copper with the apoceruloplasmin. When the copper binds with the apoceruloplasmin, so this will lead to the formation of ceruloplasmin. So the one function of ATP7B is it binds copper to the apoceruloplasmin. The apoceruloplasmin is the copper binding protein. The another function of this ATP7B protein is that it will help in the packaging of the copper into the vesicles, and these copper vesicles, they are released from this cell with the help of the exocytosis. So this another function is it will help in the package into the vesicles for exocytosis, and this copper is excreted in the bile. So what happens in the Wilson disease? So this ATP7B gene is affected. So this ATP7B protein will not be there. So what happens is there is no formation of this apoceruloplasmin and hence ceruloplasmin, and also there is no formation of this copper vesicle. So they both, the two pathways, they are affected. So the copper is not able to excreted in the bile. So this copper will accumulate in the cells, which will leading to formation of these free radicals, and these free radicals will damage the cell membrane of the hepatocyte. And what will happen here? Now the copper will come out from this hepatocyte and it will go into the blood vessel. From this blood vessel, this copper will go into the other various tissues and it will deposit there. So there will be the copper deposition in other tissues and organs in the Wilson disease. So you can see here the impaired copper transport decreases the copper secretion into the bile, which will lead to the copper overload and resultant accumulation in the liver. This will lead to the liver damage, and the copper diffuses out of the liver into the blood and then into the other tissues. So this copper, it will deposit there, and what signs and symptoms it will produce? In the liver, it will lead to hepatomegaly, it may lead to the hepatitis. This hepatitis may be acute, it may be chronic active, or it may be fulminant also. It may lead to the jaundice, and ultimately it will lead to the liver cirrhosis. in the central nervous system, it will lead to the motor deficit. It will affect the basal ganglia. It will affect the other areas of the brain also. So it will affect the. It will lead to the motor deficit. It will lead to the tremor. It will lead to the dystonia, dysarthria, dysphagia, chorea, incoordination, and it may also lead to the various cognitive and psychiatric abnormalities. When this copper deposits in the eye, this copper will deposit in the descemet membrane of the cornea, leading to formation of KF ring, also called as Kesher-Fleischer rings. These rings are gold or greenish gold in the color. This copper, when deposited in the heart, it will lead to the cardiomyopathy. In the kidney, it will lead to the renal tubular dysfunction. In the bones, it will lead to the arthritis. It will also damage the RBCs, and it will lead to the hemolytic anemia. So, how do we diagnose the Wilson disease? The Wilson disease is diagnosed the by the slit lamp examination. Here we can see here the KF rings. It is also diagnosed by estimation of the serum ceruloplasmin level. It can also be diagnosed by this deep penicillamine challenge test, and we can also estimate here the high transaminase levels in the Wilson disease. We also do this 24-hour urinary copper excretion, and the serum copper level may also be measured, but that may be high, normal, or low also. If we do the MRI of the head, we see here the face of panda appearance. But in some cases where the diagnosis is not clear by above the mentioned test, we have to go and perform the liver biopsy and for this confirmation. So the KF ring plus typical motor neurologic abnormalities or a decrease in the ceruloplasmin are nearly pathognomic for Wilson disease. What is the prognosis for the Wilson disease? The prognosis for Wilson disease is usually good, but unless until the disease is advanced before treatment begins. So, untreated Wilson disease is fatal. It usually by the age of 30. So, we have to treat the Wilson disease, otherwise it will become fatal. So, what are the treatment modalities available for the Wilson disease? So, one is the penicillamine or the trientine. They both are the chelating agents, and they will bind with this copper and they will reduce this copper level. So, they are chelating agents. Another one is the zinc. So, the zinc acetate, it will reduce the absorption of the copper from the GIT and it will lower the copper level. The other treatment modality is we have to reduce the copper in our diet. How can we reduce the copper in the diet? By avoiding the beef liver, by avoiding the cashew, black eyed peas, vegetable juice, shellfish, mushrooms, and cocoa. For the maintenance of lifelong low dose penicillamine, for the maintenance of this treatment, we have to take lifelong low dose penicillamine or trientine or oral zinc acetate. Continual lifelong treatment of Wilson disease is mandatory, regardless of whether symptoms are present or not. Right? And the copper content in the drinking water should be checked, and people should be advised not to take any vitamin or mineral supplements containing the copper. Sometime where the liver cirrhosis or the hepatic failure is there, we may have to undergo the liver transplantation, because this may be life-saving for the patients who have permanent hepatic failure or severe hepatic insufficiency which is refractory to the drugs. Thank you very much for watching this video. If you like this video, please subscribe and share it. Thank you very much.